As soon as our distinguished doctors find their seats, we would like to begin the first session. Good morning, Your Excellencies, ladies and gentlemen. Welcome to the TCTAP 2025. My name is Sripal, your Master of Ceremony today, and it is an honor to welcome you all to such a meaningful and distinguished occasion today. That is right, this year marks the 30th year anniversary since our inaugural academic conference in 1995 in Seoul, Asan Medical Center. And once again, globally renowned cardiologists are joining us this year as well. So let us open the doors to this remarkable occasion with a live case transmission from Asan Medical Center, which is a cornerstone institution in the history of TCTAP. So to lead us through this opening session, today on stage we have our moderator, Dr. Antonio Colombo, Eberhard Grube, Spence B. King, Martin Bert, and joining them for expert discussion, Dr. Sripal Bangalore, Myeong-Ki, Roxana Mehran, Duk-Woo Park, Seung-Jung Park, David Portacat, Ellen Yeung. Thank you very much for joining us today. And let us start this session. So please proceed.
Thank you all joining us. This is the opening live demonstration session from the Asan Medical Center. So, okay, Dr. Jung-Min, can you hear me?
Yeah, I can hear you, SJ.
All right, you're gonna start first live cases. We are waiting.
Yeah, good morning, everybody, audience and moderator and panels. So, first of all, I would like to thank you for all coming at the TCTAP 2025 with 30 years anniversary. This year, our meetings grew up and become the 30 years old the adult. So the SJ and we prepared, we invited many great physicians and they prepared many good lectures. So please enjoy and discuss and learn and share our experience and your experience. So please make the most of everything that we prepared for you. Anyway, we prepared one very symbolic case. Could you see the angiogram?
Not yet. Would you show us angel first? Okay.
So actually, it's a kind of a symbolic case of TCTAP. One of our theme, our theme is left main disease. In addition, functional angioplasty, functional evaluation is another important theme of our TCTAP. So we'd like to show how to evaluate, how to treat left main disease by functional and imaging evaluation. First of all, I'd like to introduce our team, the Hanbit Park and Hansu Park, many parks in our centers. And then the senior fellow, Hansu Park, our junior colleague at Hansu Park will introduce the patient brief history. Please.
Thank you, Professor An. I will introduce this case. Okay. This case is 78 years old female. She was referred for chest pain. She has been treated with hypertension and diabetes. Next. She has 3 cardiovascular risks and clinical presentation is stable angina, CCS functional class 2. Next. ECG shows no significant finding. Next. Test X-ray showed no significant finding. Next. echocardiography showed normal LV systolic function and no regional wall motion abnormality. Next. Baseline coronary angiography. Right coronary artery has no significant stenotic lesion, and in caudal view, we can see the distal left main disease. Next. In cranial and spider view showed diffuse stenotic lesion from distal left main to prox LAD and mid LAD tandem lesion. Next. Target lesion is distal left main to proximal LAD, and we planned to the IVES guidance PCI.
So actually, this patient enrolled our randomized trial, fate to main trial. Fate to main trial to compare the evaluation of left main by angiography alone versus FFR. So what is the result of randomization? This patient random to the FFR arms.
Yes.
So
FFR guided?
yes, FFR guided arms.
Right.
So SJ, do you think this left main is significant by angiographically?
Right. Why not allow it? This is the angiographic. Visually, sharp stenosis made in 50 to 60%. If you look at the spider view, would you show us the spider? Spider view clearly show that LADO still, some angiographic stenosis. However, we gonna conduct the main study. Main is we selected the FFR guided, and so we're gonna do something different with the angio guided. Dr. Mari, it's really long term. Dr. Leon, always really long time, to meet you, and so we're gonna have some.
Yes, it's been
We had this discussion about this, okay?
it's been a while, SJ, since we've been on the panel together, but I remember 30 years ago, during the first TCT Asia Pacific, we were watching you treat left main coronary disease. And
We had this discussion earlier about how you measure FFR left main.
we can't hear them, they can't hear us.
Can you hear Dr. Leon? I don't think these mics are working.
No.
Yours.
This one is working?
Yeah, maybe.
I was just
Some of the mics are working and some are not working.
going to say that much of what we've learned about treating left main coronary disease has come from watching S.J. Park and his team at Asan do serial studies and intravascular imaging and then physiology, very meticulous randomized trials. So I think it's no surprise to me that he would go on now with another randomized trial at the 30th anniversary. I mean, obviously, the way we approach lesions like this is that we believe strongly in intravascular imaging, in making preferential decisions. The left main is difficult to diagnose with angiography alone. Clearly, this looks like that there's heavy calcification in the proximal LAD extending back to the left main, with at the very least a significant lesion that may be more focal than we think at the true origin of the LAD. And that would direct us, in one place, versus, various alternatives.
So, I mean, clearly left main sometimes can be very difficult to evaluate angiographically, right? If you don't get this view, you can actually get sort of mistaken that there is not an LAD osteo lesion. I think Dr. An Jung-Min is thinking about there's also a little lesion in the middle part of the LAD, and how does that affect the overall, FFR if you want to do that as well. So I think the question here is both physiologically, how important is the whole, left main osteo LAD lesion plus the middle part of the LAD lesion, and whether you want to do a pullback and then on top of it imaging to help guide your PCI strategy and sizing.
Perhaps you would like to comment on the measurement of the FFR, because as I see, it's possible if you measure it in the circumflexes, it might be normal. If you measure it in the LAD, it might be abnormal. So I don't know how that plays in the randomized trial of left main assessment. So help us understand how you, whether this patient fits the trial design.
If the FFR turned out to be 0.84, I will still be uncomfortable to tell this patient, go home, the FFR did not reach 79.
Yeah, And I also think there is certainly the ostial LAD to me looks significant, and it's that spider view that shows it to us best. And I also see some haziness in that proximal ramus as well. So this isn't just a, angiographically things look okay, but I think given what we're seeing in terms of that spider view and the use of FFR, I wonder if you would be happy with FFR without imaging. And I wondered if Dr. An would tell us, will you allow in the FFR guidance to use imaging, intravascular imaging, especially in the left main?
Great. So, Dr. An, would you show us how would you, use FFR for this kind of tandem lesion? There are some, middle portion of intermediate stenosis and critical LAD lesion. Would you show us something?
Okay.
FFR?
Yes. So we already measured the FFR. Could you show us the FFR value? The full LAD vessel FFR was 0.78.
Okay, good.
And to evaluate the tandem lesion, we need the pressure via pullback curve. So we can measure the pressure step up the before and after the tandem lesion. So we pressure via pullback gently and show that with the LAD lesion pressure gradient to gradient to step up was 0.06. The left main is 0.1. So the pressure gradient of proximal left main is greater than with the LAD. So we'd like to treat the left main first, and then we evaluate the FFR for further treatment of with the LAD lesion. So in addition, if the FFR, with the LAD FFR is not that significant based on the Will Ferron's studies, significant means around the 0.5 or 0.45. The with the LAD stenosis doesn't affect the left main FFR too much. So I believe based on the FFR value 0.78 is below the 0.80. So I think it is a value justify the left main stenting.
Great.
So in this randomized trial, the intravascular imaging did not affect the decision-making scenario. But for the treatment optimization, definitely we use the intracoronary imaging. So this patient was assigned to the FFR arms, and we evaluate the FFR. Our decision is to treat the left main. So, and next step would be the evaluation of IVUS from LAD side and circumflex side.
Before the imaging, in these cases, look at the angiogram more carefully. What I mean is look at the angiogram in the septal, in the just proximal. Look at the size of the LAD, and look at the left main. Left main is smaller than the LAD. Is there a real normal left main? No. Angiographic itself is there is some severe disease. So before the intracoronary imaging, we have to realize from the angiogram itself.
So
Yes,
what is the next?
that's important comment. So could you show us the intravascular imaging from the LAD pullback, just above the septal branch? Run, please. So this is the LAD IVUS pullback from the above the big septal branch. Septal branch is here. So here is vessel size is all. This is distal lesion. So here is the septal branch. I'm sorry. So this is above the septal branch. Vessel size is 3.5, very mild plaque. And here would be a good distal landing for the left main stenting. Very mild plaque. It looks like very soft. Yes, it's very proximal of the LAD and bifurcation, very calcified left main disease. Not that significantly tight, but the FFR is lower than 0.80. This is a very ostium of left main. Here is the left main ostium. So disease extended from the whole left main segment from the bifurcation to the left main ostium. Could you show us the circumflex?
circumflex ostium is good, right?
Yeah, spider view, please. Show us the circumflex. Spider view, please. So the angiographically circumflex ostium looks fine, but intravascular imaging also sometimes give us another idea. But this is a very circumflex ostium. So could you measure the circumflex ostium? The recent our analysis show that the circumflex ostium plaque burden more than 65 and lumen area less than 3.7. Combination of two factors increase the acute procedural complication after simple crossover stenting. But thankfully, this patient lumen is larger, plaque burden is less than. So I think that after simple crossover stenting, it will be some pinched, but I think safely we can do the simple crossover stenting for this particular case. So before the stent, so Roxana Mehran already mentioned that there is a very calcified lesion at LAD ostium and this left main. So pre-lesion modification is very important. So vessel size is more than 3.5. So I'd like to apply the pre-lesion modification using 3.5 high pressure balloon.
35,
Yeah.
right?
Test, please.
Would you have considered lithotripsy here because of the degree of calcium? I saw pretty large calcific arc there, and it might be something that
Influence the optimal stent expansion. So I'd like to recommend the more the high pressure.
Yes, I agree. So 20.
Well, the other
24.
feature that
A little bit of the
influences
indentation,
plaque is
look at
the
carefully.
duration of inflation. I would be leaving the balloon up a little bit longer than brief inflation to try to really affect that plaque composition and prepare
Inflates
the
quite,
lesion.
quite symmetrically. Yeah.
Yes, according to the Dr. King's opinion, so we inflate the balloon more than 30 seconds. So deflate, and then we saw the not fully but acceptably expanded high pressure balloon 3.5. In addition, could you show us could you suggest the stent length and stent diameters based on the IVUS finding? I'd like to cover the left from the left main to the above the big septal branch.
So you're gonna
So what is
do,
the size? 3.5? I think 3.5, 30 millimeters.
I thought your LAD looked like a 4.0. Maybe I'm just over-exaggerating, but maybe you could tell us, because from IVUS, in that landing zone, it looked like a 4.0, even in the proximal LAD, and left main should be even larger than that. I just don't want you to expand there.
Usually, I'd like to implant to avoid the edge problem. I like to select a little bit smaller stent size, and then after IVUS evaluation, after stent implantation,
You'll
and I'd like to,
post-dilate. Yeah,
yes, I
that sounds
applied
good.
the, yeah.
Before you do an angiogram, what do you think the likelihood is of having a significant dissection down that LAD circumflex bifurcation that will give you problem?
Test it, please.
okay. Just stent crossover, right?
Yes, test it, please.
Like,
Okay. Test, please.
further.
Test it, please.
You want to cover from the origin of the left main all the way down, right?
Yeah, test it, please. A little bit more.
Oh, still part of the main is okay, right? So you
Okay. 10, 12, 13, 14. Deflation.
all right. Actually, circumflex ostium part is, looks normal, and so we don't care about the, the stent crossover.
20,
20.
This giant sustain 3.5, 30 millimeters deflation, 33 millimeters.
How is the patient tolerating the inflations?
Yeah, most patient, even the longer duration of ballooning at the left main, most patients are tolerable to the balloon inflation during the 10 second or 20 second. If there is if you see the blood pressure going down, then you have to release the balloon inflation. Ready?
네.
Okay. So let's see IBUS.
Okay. Would you show us
spider
again
view.
spider view, Dr.
Yeah.
Aran? All right, great.
We all want to see the spider view.
Okay. Ready? Oh, something. So anyway, after the vital sign is stable, patients don't complain the chest pain, and EKG looks normal. So after the LAD evaluation, I will decide to treat or not treat the further the circumflex.
So angiographically a little bit, compromised,
Because the angle coming out was
circumflex
always a
however,
bit, acute, right? So therefore, you're going to be some plaque
Run,
shift and pick up
please.
stand struts as well.
I selected 35. Distal landing looks fine. Where pose stand. And expansion looks fine.
Perfect.
For all 3.5. Circumflex coming from the 12 o'clock. The opening looks fine. Then I want to cover the ostium of left main. Let's just see. Okay.
Perfect positioning.
Very good, very
Position
good
looks-
coverage and fully expanded.
Yeah. So I think we need further dilatation using the 4O. Before that, I'd like to change. Talk, please.
Yeah.
Good. Perfect.
Jung-Min, are you concerned about the haziness of the intermediate on the circumflex?
Sometimes before high pressure balloon, I like to keep the wire to the side branch.
Yeah.
So this is LAD, side branch wire, and then change to the LAD.
Yeah.
Great.
So please give me the 4O high pressure balloon.
It is some interesting to what happening after the high pressure balloon and the distal bifurcation. What happened in the ostium of the circ?
There's no question that the ostium of the circ will deteriorate. That's expected. Unavoidable.
So 10.
Just because it's an
This is the 4O high pressure balloon deflation. So side branch is a side branch. So LAD optimization, LAD to left 20. The LAD to left main to the LAD optimization is more important than concerning for deflation for side branch. So after left main to LAD stand optimization, I do concern for side branch. 10, 14, 16, 18,
18,
20,
20,
deflation. So I think I'd like to see the IBUS and what happened after the high pressure balloon dilatation.
Without the IBC examination, anyhow, it looks
Ready?
very perfect expectation.
Ready?
Great.
Okay. IBUS.
So that's perfect, right? So,
Yes, circle looks fine. There is some haziness, mostly due to some calcification or
Not
some
this view.
sensor.
Spider view.
Spider view.
Yeah. So the first stand evaluation, usually we do not use the FFR, but sometimes the circumflex concern after simple crossover stenting. FFR is very useful. If FFR is negative, we don't need to further procedure for circumflex. So I think I'd like to measure FFR for circumflex.
After the full balloon dilation, the distal margin of the stent is widely open.
Yeah.
great. No model positions.
And the eccentricity of distal bifurcation is much improved.
Great. If you measured stent areas for the remains, you made a new cutoff value for that.
Yeah. 11 point something. I think the left, after simple crossover stenting, proximal left main stent area is the most important. Area more than 11, eventually is very rare. So, ready? Left main to LED stent, I think it's perfect. But my concern and your concern was circumflex. Ready?
It's perfect.
Yes, it looks better than before. So
Looks
do you
fine.
want to do something more, or
No.
what is your idea? So yeah, that is very important. So because we know after simple crossover stenting, based on our small sample size studies, after simple crossover stenting, FFR value less than 0.80 is only 7%. Most FFR value after left main simple crossover stenting, FFR is more than 0.80. So if you want to do more for circumflex, then we can measure the FFR to avoid the unnecessary procedure. But the left main final kissing balloon, if the TME flow circumflex is 3, then final kissing balloon did not improve the patient outcome. Rather, sometimes increase the event rate to the membrane. So that is my concern. So I don't like to touch more for circumflex.
In regarding to in the left main,
Yeah.
usually the angio-guided PCI cases is recommended is 1 to or 1.1 ratio the expansion. But when we look at the angiogram, it looks like more than a 1.1, more than looks like 1.3 is the expanded appearance. That is the typical appearance of the imaging guided PCI appearance.
Why don't you do an FFR on the circumflex?
Yeah, that was
I'm
exactly
still,
my.
I mean, you have the FFR wire, no matter
Yeah,
what.
okay.
I mean, it's a big circumflex.
This is FFR guided.
I think.
Because, Antonio, if he
Actually,
does an FFR, he might talk himself into treating the circumflex.
Yeah, well, nothing
He
wrong.
doesn't
I mean,
believe- he doesn't
why
believe that's
are
necessary.
we afraid to treat a lesion? It's our business.
Antonio, we're going to do not enough time to measure the wholesale FFR. However, based on our data, more than 90% of this kind of a compromise is negative FFR, right? We got some data about that, and so we don't care about too much about, circumflex osteotomy.
It's nice to see.
So, Dr. An, would you show us a FFR for that? Circumflex?
Yeah.
All right.
It's the top
gonna do it.
branch, yeah.
Take the reins.
Could you show us the AP caudal view for the azimuth of the circle.
There you go.
In the
Take that, Ray.
region in the spider view, is the azimuth of the circle looks like the pinched, but if the other view, AP coronal view is wide open, it means that some eccentric narrowing. So it means that there is some sufficient space to flow to the circle.
So I like to measure because we need to evaluate it. So very ostium.
That is a direct way.
Okay. So could you show us the FFR pressure gradient?
This is in the Ramus now, not
Yeah,
the
yeah.
which I'm really happy you're doing.
Because we need more curve.
No, but that's okay. That looked normal.
How do I pass through the circumflex proportions, right?
Because we need more curve. You know the FFR wire is not easy to manipulate. Sometimes we need more curve, sometimes not. Test, please.
Sorry.
Test, please.
Great.
Okay.
Great. That's
So
that's maybe better
equalization,
than
please. Just a moment.
That's much better.
So equalize the pressure, please. Yeah. So for the left main evaluation, guiding catheter disengagement is very important. Could you equalize the pressure between the pressure wire and guiding catheters? And then pressure sensor located in the proximal tip of radio opaque markers. So I like to insert the wire to the distally. Many side branch. Test, please. Oh.
Would it be any problem to go ahead and take that side branch and put your transducer just distal to the origin of the circumflex, and it still should be a good reading.
So instead, the insert, I think instead this, if I fail to insert the FFR wire to the distally, then I like to insert it to the OM branch, second OM, third OM, something like that. Okay, so.
Yeah, like that.
There is not a problem.
Okay, because I'd like to evaluate the ostium only. Okay, flushing. So resting PDPA is around 0.89, 0.90, 91. Could you give the adenosine, please? The resting PDPA was 0.93. I presume that the final FFR would be the 0.81 or 2.
All right. Maybe 7.9 something. I think it's okay. It's all right.
It took 2 or 3 minutes to achieve the maximum hyperemia. Usually, we are using the intravenous adenosine infusion, sometimes up to the 200 microgram per kg per minute. So far, no pressure drop. No change in the pressure. Okay, pressure drop. 9, 89, 87, 85, 84, 3, 2, 1, 79.
No more than.
79, yeah.
Stop. Great.
Yes, 7-8. So 7-9, 7-8. Yeah. So similar to my first guess, this is very gray zone, borderline zone. So we can apply the balloon angioplasty, but I think I'm happy to see the 0.8 something, the FFR for the circumflex. So
and the wire is quite proximal. If you advance the wire more distal, it's going to go to 7.5.
I think in the case of a circumflex, sometimes FFR sometimes increased because of hydrostatic pressure.
Today, just we want to show that FFR. However, in our real practice, we didn't do the FFR.
Right. I will leave it alone. Yeah.
Right. Anyway,
So
Dr.
FFR
Han, we got a limited time. It's very
Okay,
good.
ready?
Right.
Ready?
Last pictures, though.
Please, AP caudal view.
Ready? Ready?
Great.
Okay, the circumflex fluid TIMI 3. Actually, TIMI 3 we don't need to do something for the left circumflex. And then left main and LAD stand is very expanded, full cover from the proximal LAD to the left main ostium. So I'm very happy to show this result.
Beautiful.
Do you have any comments further?
All right. Dr. Han is really great cases. It's a typical representative, main FFR guided. Thank you again for your contribution. Right. Thank you.
Thank you.
Thank you. Thank you very much. We would like to invite your back. Thank you very much. Why don't you give another big round of applause to our all doctors? Thank you.